We now see your next slide.
Yeah, I'm trying to. Okay. I think we can get started. Thank you so much. Thank you for those who managed to join in time. Greetings to everyone. Good morning, good afternoon, depending on where you are on the map. Welcome to our webinar series on Global Men and HIV Technical Working Group. This is a series of webinars where we cover topics that are important to addressing the HIV services gap among men. So basic housekeeping, we are recording this session. We will share the slides and the recordings after the webinar. I would like us to make it a very interactive session. So let's all engage using the chat function and also the Q&A function. There is those two separate chat functions that we can use. If you want to ask specific questions to a particular presentation, feel free to use the Q&A function. Our panelists, they've got access to that function. If you just want to share information, engage with other participants in this webinar, make use of the chat function where we can make it a more interactive session. Also to let you know that we have got English, French, Portuguese, and Spanish interpretations as we go through the webinar. You just need to look at the globe looking like icon at the bottom corner of your Zoom window, and then you select the language of your preference based on those languages provided. So about MENT, as we know, a number of us, we always get new people joining this webinar series as you get information about them with time. So we always like to give you some bit of background about this global technical working group. This MENT group was launched in 2021 in March, basically to address the HIV services gap among men, based on what we see from different data sources, be it HIV estimates data, be it program data, be it scientific research data looking at HIV transmission dynamics. That just makes us see this huge challenge that we see among men that needs to be addressed. So this global working group, it focuses to address that gap we see among men. Basically what we do with this group, which is coordinated by UNAIDS and WHO and co-chaired by UNAIDS, WHO, ILO, PSI, and IIS, we make effort to coordinate all the different work across the HIV cascade addressing men. We also work to try and support the development of operational guidance for improving HIV services for men, as well as engage with all of you to identify as well as provide a platform to share best practices on reaching men or on engaging men. Also as a platform, when we get hold of any new tools or guidance, we make it as a platform to disseminate and share those tools for those who are working on this topic. We started off soon after launching the group. We started off in 2021, soon after the launch, with the first series of these webinars looking at the data, just for us to be able to know why are we talking about men and HIV. So the first series of webinars looked at the different data available and also some of the key approaches on engaging men that were shared during this first webinar. We have covered a number of these different webinars for those who are joining for the first time in this episode. There are links to all these different webinars that we have covered since we started this group, and the last one shown in red there, which is the webinar for today, that is going to be focusing on men and PrEP, which is a second part of this topic we did end of last year a part 1 on men and PrEP, and there were interest from some of you to go into other topics focusing on men and PrEP. So today, luckily, we are lucky to have an excellent panel. Those who attend conferences such as the CROI, you might have seen some of these faces, as some of them have presented their work at such kind of conferences. So we will start with WHO guidelines around PrEP with an emphasis on men. We covered this in the last part 1 of men and PrEP, but then we could see that there were a lot of questions around guidelines. So we asked Robin from WHO to spend a few minutes with us to just highlight those guidelines, but then use the rest of the session to go into detail and give you an opportunity to ask any questions that you might have around men, around guidelines on PrEP from WHO perspective, with a focus on men. And then we'll hear from Sheila Shinoy from Yale University, who is going to present on feasibility of community-based PrEP delivery models among bar patrons in rural South Africa. After Sheila, we'll hear from 2 presenters, Alexander, as well as Victor. Alexander from University of Washington and Victor from Cambridge in Kenya. They're going to share with us their work on reaching men with pharmacy-based HIV PrEP delivery in Kenya. And then we'll hear some results of the search study. James is going to present to us search study insights on men and PrEP/PEP in rural East Africa. Some of this work was also presented at CROI early this year. And then we have some time to do questions and discussions, and then closing remarks from my colleague Wale from WHO. I wanted to just highlight here, there are slides that we have put here as part of the introductory part. You will get these slides at the end of the webinar, but just highlighting what are some of the successes and some of the challenges around PrEP scale up. I won't go into detail into this as we have a pegged agenda. I don't want to take time into those presentations, but we've made some of this information available, highlighting what are some of the successes that we know about PrEP and what are some of the challenges. We know some of the successes have to do with known results of some studies showing decreased HIV incidence. We know that in some countries, there've been increased access, with some countries setting up national programs on PrEP. And also we know that there's been some increase in awareness around PrEP. But we know there are also challenges as well, such as stigma and discrimination around PrEP, limited funding, and also health system capacity that pose challenges in the scale-up of PrEP. And as far as how countries have gone, this chart is showing that there's been an increase in PrEP scale-up over time from 2016 to 2021. However, we might think that we are doing well as far as the PrEP program is concerned, but if you look at how that scale-up is as compared to where we need to be, shown by that orange circle at the top there, by 2025, you will see that the rate of scale up is very slow for us to be able to achieve that target. Otherwise, it has to show exponential increase if we are to meet the 2025 targets. This just highlights the amount of work that is really needed to be done as far as PrEP is concerned. We have global PrEP targets that are distributed across the different regions, with the different regions based on epidemics, showing that they need to do in proportion to those different targets, with Asia Pacific with the highest target, and shown by those red straight lines at the top of the blue bar. The blue bar is showing what countries have done so far towards that target. ESA, we can see the ESA region is leading as far as their progress towards the target, with other regions lagging behind, and with other regions having a huge gap as far as achieving the target is concerned. As far as men are concerned when it comes to PrEP, we know there's been some successes. We will hear some of these successful stories from the presenters today, but we have seen overall that there's been increase in awareness of PrEP among men. There've been increase in or improved access to PrEP among men due to different programs. We also know that there's been better adherence from other programs as far as PrEP is concerned. But also we know stigma also is a challenge around PrEP. Healthcare provider training to target men is a challenge, and also cost is a challenge as far as access to PrEP for men. I'll skip this other the last slide, but basically it's just summarizing what are some of the innovations that have been done in order to improve PrEP access among men, so that I can give time to our presenters. The first presenter is Robin. So over to you, Robin, to take us through the guidelines, and then we'll hear from some of the different studies done by the different groups in this webinar. Over to you, Robin. Thank you.
Thanks, Lucius. If you just stop sharing, I will share my screen. So hi, everyone. Thanks for inviting me and having me here. I'm largely here to answer questions specific to WHO guidance. Can you confirm you see this in full mode?
Yes.
Yeah.
Thanks, Robin.
So I have only a very few slides to highlight a couple of things before we can go into questions. So my name is Robin Schaefer. I work with the WHO HIV, hepatitis, and STIs programs in Geneva, and I'm presenting on behalf of our PrEP team as listed on this slide, specifically focusing on this document that was published last summer in July, which updates WHO implementation guidance, focusing specifically on making PrEP delivery simpler and more differentiated. So the overarching aim of this document is to support differentiated, simplified, demedicalized, and comprehensive PrEP services to make services more acceptable and accessible, and thereby support uptake, persistence, and effective use of PrEP, maintain quality and safety of services, and support the achievement of the global goals for PrEP that Lucius just mentioned. It covers a broad range of topics, from how to start, stop, and use oral PrEP. There is guidance on integration for hepatitis B and C, updates to kidney function monitoring guidance, HIV self-testing, and a large chunk of the document is dedicated to differentiated service delivery. I'm just going to focus very briefly on the topic around starting, using, and stopping oral PrEP, because that's where a lot of questions often come up, and which is specific to the interest of this group. So the new guidance is summarized in this figure and in this table. And I think if I can just focus your attention on the top part of the table in the slightly darker blue color, and the guidance now states that all cisgender men and all other people, be trans or gender diverse, who are assigned male at birth, who have sexual exposure and are not taking any gender-affirming hormones, can follow the following guidance to start and use and stop oral PrEP. That is, to start with a double dose of 2 pills or 2 doses 2 to 24 hours before sexual exposure. Ideally, they should be closer to 24 hours before the exposure. Then you take 1 dose a day as long as the exposure continues. And then you stop by taking 1 dose per day until 2 days after the last sexual exposure. So this is regardless of whether you just want to take PrEP for a single event, or whether you want to take continuously. You can start with a double dose and then stop with 2 doses. And if you do it in an event-driven way, just for single event, this is sometimes referred to as event-driven PrEP or ED PrEP, or also as 2+1+1, which summarizes the kind of dosing schedule. So just that's a major change to previous guidance, because the eligibility to this approach to start and stop oral PrEP with the 2 doses to start and 2 doses to stop has been broadened to include all men, that is all cisgender men, while previously it was very narrowly defined that this is only suitable for cisgender men who have sex with men. But this is now broadened as unrelated to your sexual behavior. It's really just about the population, and it's not necessary anymore to disclose, for example, that you are having sex with men. And we hope that this simplifies makes this approach more accessible to a broader range of individuals and simplifies the pattern of PrEP taking. And of note here, just because that's also a major change, is this approach, this event-driven PrEP approach is no longer requiring to be free of hepatitis B virus, or hepatitis B is no longer a contraindication. And I'm just mentioning in one sentence that the bottom half of the table, for everyone else who is not covered under this broad bucket of cisgender men and transgender diverse people assigned male at birth, everyone else can start PrEP with 7 doses once a day for 7 days, and then stop with once a day for 7 days. So that's just something I wanted to focus on and reiterate the guidance, and not really going into anything else that is in that document. Just referring here to a few more resources. I should have also put on the last technical working group webinar from last year, where we spoke about this in more detail, but WHO has done a webinar around the guidance. There was a session at the last year's AIDS conference that you can watch, and there's also some more resources from the International AIDS Society. I'm just going to stop here. So that was just very brief. There are a lot of resources you can look up, and I'm just here to answer any potential question you have before we go into into the rest of the session, where we hear more about all these great examples of how to provide PrEP in a differentiated way. Thank you. So if there's no question, I will stay on the webinar and can speak to anything that comes up as we go along.
Thank you. Thank you, Robin. Yes, I hear your voice, Wale.
No, I was waiting for you to come in, so you can please go ahead. Thanks.
Yes, I was going to maybe give a few seconds to see if people can raise hands if you want to speak, or if you want to send your question in the chat for Robin. I know there are always clarifying questions around guidelines. I see Sean's hand is up. Over to you, Sean.
Yeah, Robin, thanks for that update. One thing we've observed in some spaces is some reluctance to really move ahead with this differentiated service delivery under PrEP, particularly given the gender differences and concern about mixed messages and confusion and possible misuse. Does WHO have any insight or perspective on how to handle this properly from the communication side?
Yeah, I mean, I guess it's, in a way, we're trying to make it simpler by just very broadly distinguishing between two types of populations, and then you have 2 different approaches. And I see that, you could argue it's slightly more complicated than one rule for everyone, but that would obviously, prevent people from taking event-driven, or this more simplified way to start and stop oral PrEP. So, I mean, it's fairly general questions, but, we have now experience, for quite a while, as Lucius pointed out, with oral PrEP, and it's certainly possible to implement PrEP services that focus on MSM, who often take PrEP in the event-driven way. So we have experience with that. We have far less experience with, expanding access to that to all men, meaning particularly also heterosexual men. So that's just something where we still learn. But, I think it just becomes very important that we, at the counseling stage, when people are initiated, to make sure that we get the message across. This is appropriate for your specific circumstances. Either, you start and stop PrEP this way, or you do it the other way. And of course, some countries are moving forward in changing their guidelines to allow a broader group of people to use PrEP in an event-driven way, or at least start in this way. So we'll get more experience. For example, in Malawi, Malawi has recently updated their PrEP guidelines to include this broadened eligibility to all men that they can use event-driven PrEP. So we will get more experience how countries are implementing it, but it is something where the counseling becomes very important. Thanks.
Thank you, Sean, and thanks, Robin, for those clarifications. Do we have any other clarifying question from colleagues before we can go to the next presentation? And also, as Robin highlighted, he's available throughout the webinar, so feel free to also still ask a question through the chat box. He's got access to the Q&A function. He can be responding to your questions using that function as well. If you raise your hand, we can allow you to unmute if you want to speak. Thanks, Chris. I see a point from Chris from Global Fund highlighting that the messaging and communications need to be super clear on IC materials.
Can I just respond to the question I was just put in the chat? Thanks for that. We currently do not anticipate that this event-driven way to use PrEP will be broadened to include people who are assigned female at birth, or women, cis women. The reason for that is that there are some biological differences in the differences in the pharmacokinetics of TDF-FDC bisex, and it takes a longer amount of time basically in women to reach protective levels of the drug once you start taking PrEP. So we do not currently anticipate that this approach can be suitable for those assigned female at birth, so cisgender women. Well, if I can just make one more comment, sorry, while I have the floor. What we will see in upcoming guidance from WHO, so we are in the works of updating the PrEP implementation tool, which has been around for quite a while now, and particularly the clinical module we are aiming to update. And in that, we were actually kind of we're moving away a little bit from the language of distinguishing between event-driven and daily oral PrEP, because we think that distinction is a bit arbitrary and not really reflective of how people take PrEP, because we know even for, say, cisgender women who have to take 7 doses once a day, so 1 dose for 7 days to start, they do not actually take it continuously. So in a way, they may also start and stop and restart, etc., based on their perceived risk or actual risks. So that, is in a way could also be described more event-driven. So we will in that future guidance more focus on how to safely start and how to safely stop PrEP, and no longer really distinguish between just purely event-driven and daily PrEP, because it just, as I said, that distinction is a bit outdated, we think, and it's more about how we can safely start and stop. I mean, it's a very the question about anal sex among women it's very complicated, and I do not anticipate that we would change the guidance specifically focusing on this, because while we know that anal sex is common also among cisgender women in various parts of the world, most women who have anal sex also have vaginal sex, and it would make it quite tricky to have specific guidance just focusing on that. So I would not anticipate to extend that, and I'm also not 100% sure about the pharmacokinetics in that regard, because it probably hasn't been studied very much. So probably not is the answer to that.
Thank you. Thanks, Robin, for those responses and clarifying those questions we see in our chat box. We can go to the next presentation, and as we highlighted earlier on, feel free to still send questions related to guidelines to Robin via the chat box there. He's going to be responding to them as we go through the different presentations. The next presenter is Sheila Shinoy, who is going to share with us results of the work they're doing in South Africa. Over to you, Sheila.
Thank you so much. So I'm sharing my slides.
Okay.
Thank you everyone for having us today. This is a very exciting group of presentations. On behalf of my colleague and myself, Dr. Anthony Moll, who is here in the audience, we'll be presenting feasibility of a community-based delivery approach among bar patrons in rural South Africa. So just by way of introduction, this is a very rural part of South Africa. This is in Tegela Ferry on the east in the province of KwaZulu-Natal, in the very center, with a high, very traditional Zulu population, with a high HIV antenatal prevalence, and very poor, impoverished population served by government district hospital and primary care clinics. And we have been very focused on community-based approaches for engaging high-risk populations for HIV and TB testing and linkage to care. We have focused on integrating services at a community level with non-communicable disease screening. We have targeted congregate settings and households. And ultimately, we have found that we are largely missing men, and particularly young men, from these from our testing populations. And we have very much overall focused on, through all of this work, on trying to meet people where they are. And this is just some photographs of what this looks like on the ground, in person, group level education, and individual level counseling and testing. So again, where are the men if we are not finding them in the congregate settings in the community, if we're not finding them in households? In our rural area, it was a very short list of places where people gather. And at the top of the list were shebeens, or alcohol-based venues. It's a very common place for people to socialize. And unfortunately, in South Africa, the proportion of these kinds of venues has grown. Overall prevalence of actually even alcohol use disorder has grown, now 7%, and much greater than any other place on the continent. So we wanted to know, if it was feasible to engage young people in community settings, such as these shebeens. Is it feasible to conduct HIV testing, particularly targeting young men? And I'll just share with you briefly our experience. In this sample of more than 1,300 people, we were able to identify a large proportion of people who were living with HIV. And ultimately, this was a group of largely young men that we engaged for testing, a substantial proportion of whom had not been to a clinic for other health reasons, and who had a high proportion of concurrent alcohol use, tobacco use, marijuana use, and had definite risk factors for HIV. So, and you can see here in the orange, men who were tested at shebeens in the orange versus blue were women testing, and people who were living with HIV identified through this initiative were much higher at shebeens. So was it feasible to engage young people at community settings? Yes. Was it feasible to conduct HIV testing and to reach young men? Yes. And then we wanted to know, was it feasible to provide PrEP in community settings as well? And so that's going to take us right into the main focus of our presentation today. So we use our similar community-based screening platform where we offered community members, and in this case, focusing outside of shebeens, offering community members comprehensive health screening, so including HIV testing, TB symptom screen, blood pressure check, finger stick for blood glucose, STI screening, and we also included, as part of our questionnaire, audit scale for alcohol use. And I will just make a note of the fact that our community team team was the community health worker team that was performing these screening, as well as the nurse who accompanied them were all men. Those that were without HIV and that were eligible for PrEP according to local guidelines were offered enrollment. And initially, though, we had planned for follow-up at 1 month, 4 months, and 7 months in the community, and followed by transferring to the primary care clinics. Ultimately, COVID did disrupt our plans for that follow-up, and ultimately we transferred people to the primary care clinic after the 4-month follow-up. But through all of this, community visits were housed all of the services. Participants did not have to go to the clinic at all. And again, this is just some photographs from our community team, again, focused on men. This is Dr. Megan Grammatico, who helped coordinate this project, but all of the community member facing staff were men. And this slide is just to, again, highlight what was done at a community level versus elsewhere. So again, in the community, people were approached outside the shebeens and offered health testing. Those that were eligible for PrEP were then referred to have a separate conversation on a separate date and time at a location of the participant's choice. So that could have been outside of shebeen as well. That could have been a community center, that could have been outside of their home, that could have been at the NGO offices. And then the participants, all of the screening, the clinical evaluation, and initiation was done again at a community level with our mobile clinic. And follow-up was done in the community. And then ultimately after the 4-month follow-up, people were transferred to the primary care clinic. This is a busy slide. So I will focus on, excuse me, on this slide, which is looking at the independent predictors of uptake. On the left side of the screen, you'll see among all shebeen patrons, it was largely younger community members and those who had a higher number of sex partners lifetime that were reported, that uptook PrEP. And then amongst the men only, it was younger men who had higher numbers of sex partners lifetime, and those that had not attended clinic before, although this was not a significant factor, that ultimately started PrEP through this pilot. So our takeaways from this are that this type of community-based approach did target successfully a hard-to-reach population that is engaging in high-risk behavior, and that the predictors of PrEP uptake were younger age, male sex, a median number of sexual partners, and those that did not generally attend primary care clinics or otherwise engage in care. So is it feasible to provide community and PrEP in community settings? The answer to that is yes. So we take away from this that community-based model of PrEP care is promising for reaching young men, and that hazardous alcohol use is not associated with PrEP uptake and retention. Just to focus a little bit more on some of these findings, that most of the men reported that they never visit the primary care clinics, which is the main source of healthcare in this region, and that there were a substantial amount of comorbidities amongst the PrEP initiators as well as the non-initiators, including comorbid alcohol use, tobacco use, and marijuana use. The limitations of this include that this was a pilot. Obviously, just like every other sector of health services, this was disrupted by COVID. Our original plans did change. And that this is really targeting a certain population. And so maybe not appropriate for other target populations, including adolescent girls and young women, or those who are not attending shebeens or alcohol venues. I do want to spend just a couple of minutes focusing on our evaluation. We did have the opportunity to evaluate this model by qualitatively interviewing participants. We interviewed 20 of them, and overwhelmingly, the participants were highly satisfied with not only HIV testing, but also the PrEP provision in the community. A couple of our respondents did report concerns about privacy and peer pressure. As mentioned before, there was group education, but then all testing was done on an individual level inside the mobile clinic. And when people exited the mobile clinic, if they were there, they should be with friends. Friends may have pressured individuals to reveal their HIV test results, for example. That did come up in our qualitative responses. Other challenges to initiation and adherence to PrEP among respondents were that people were concerned about being mistaken for HIV, living with HIV and taking ART instead of PrEP. People were concerned about the daily pill burden. People were concerned about traveling to the clinic on a regular basis to continue PrEP, and concerned about being able to take medications on a regular basis given their ongoing alcohol use. So they did cite individual strategies that they could take advantage of, including alarm reminders on their cell phone. They did cite social support from family and friends to help them with PrEP. And they also felt that the rapport with the community nurses, and in our pilot, this was all men, was very important for them starting. And then when we transferred people to the primary care clinics, the participants, again, this is largely men, did perceive that they would have difficulty accessing the clinic because of the queues and conflicts with their work hours. There were some cultural and gender norms issues that led to concerns about stigma, that only people with HIV attend the clinic on a regular basis. And so again, that they would be mistaken for someone living with HIV. The concerns that, they were being seen as potentially being ill, that the clinic was not a welcoming environment based on previous negative interactions with nursing staff. They very much appreciated the community-based model for the convenience of the medication delivery. The fact that it was a similar team, the same people that they were interacting with on a regular basis. And the fact that, as mentioned earlier, it was male nurses and male community health workers who were the primary people they were working with over time, not only for the PrEP, but even earlier with the HIV testing. And they felt more comfortable with them and helped them avoid that perceived stigma. And then we asked them about how we could improve this model. And the men's suggestions were that we should be visiting the Shabeens more frequently on a regular schedule. They suggested expanding to other sites, including sporting events, using unmarked cars for home visits, assisting with facilitating PrEP disclosure to family and partners, using champions or ambassadors. And there was a lot of interest in injectable PrEP as well. So overall, I'll just leave you with that community-based approaches are useful adjunctive strategies to contribute to case finding and linkage to care, peer navigation, community health workers, and specifically using gender concordant care may be useful approaches. And that community-based models of PrEP delivery are feasible and can reach those who do not access clinics. And then lastly, that alcohol use disorder is an important comorbidity among young men in particular. And this must be addressed if we're going to appropriately address and engage people for HIV testing and prevention. So just wanted to acknowledge our team. Again, Dr. Anthony Moll is on this call. The rest of our team, Sianda, Sujozo, Bona, Megan, and the staff, and particularly the nurses at Church of Scotland Hospital in Taylor Ferry. Thank you. I see questions in the Q&A. We did, yes, definitely promoted condom use and distributed condoms. There was another question about objective drug level monitoring. We did not do drug level monitoring in this project. But that is a good point and something we could consider for the future.
Thank you so much, Sheila. And let's keep on posting our questions in the chat function. And we can go to the next presenters, Victor and Alex, who are going to present on pharmacy-based PrEP delivery work they're doing in Kenya. So over to you, Alex and Victor. If you still have got any clarifying questions for Sheila, feel free to post them on the chat box. She'll respond to them as we go through the webinar. Over to you, Alex and Victor.
Noted. Thank you, Dr. Shenoy, for that presentation. Let me just get this started. Perfect. Just want to confirm everyone can see my slides.
Yep.
Lysias, great. Thank you. Thank you, Lysias and team, for this opportunity. Excited to be here. My name is Alex Kuo. I'm from the University of Washington, and I will be co-presenting with Dr. Victor Omolo from KEMRI, the Kenya Medical Research Institute. We will be presenting on reaching men with pharmacy-based HIV PrEP delivery in Kenya. So for some background, in many African settings, HIV pre-exposure prophylaxis PrEP is primarily delivered at healthcare facilities with quarterly clinic visits for HIV testing prior to refills. So this is often standard of care. And in these settings, men often engage less with facility-based HIV services compared to women, who often access these facilities for family planning and antenatal care services. So they are often more active in healthcare systems. This often results in men being less likely to access preventative services, more likely to present with late-stage HIV, resulting in higher mortality, and more likely to drop out of HIV care services. Differentiated community-based models of HIV service delivery that operate outside healthcare facilities might be better suited for reaching men. And this is because men often have economic power and can potentially pay for these services outside of public sector services. Private retail pharmacies are ubiquitous in many African settings, such as Kenya, and have been underutilized in HIV service delivery. Thus, delivering HIV services here might help potentially reach men. So Dr. Shenoy touched on some of these barriers as well, but the potential for pharmacy-delivered PrEP services may help alleviate many problems faced by these standard of care public HIV clinics. This includes stigma at these clinics associated with visiting a HIV-specific clinic when you're HIV negative just on PrEP. This is due to pharmacies servicing a wide range of health conditions. There are also limited hours of operation for clinics, being primarily on weekdays, which is challenging, unlike pharmacies. And they usually have long wait times and increased travel distance, and as lack of privacy due to overcrowding and limited number of clinics when compared to pharmacies. We collaboratively developed a pharmacy PrEP delivery model with Kenyan stakeholders in a one-day meeting, and this was informed by some formative qualitative research that was adapted from a model of pharmacy delivery PrEP services in Seattle, Washington, United States. On the right, we can see our simplified prescribing checklist that pharmacy providers used in one of many steps to deliver PrEP safely and in accordance with the Kenyan Ministry of Health guidelines. This included a HIV risk assessment tool, assessment of PrEP eligibility and ensuring no contraindications to PrEP, a negative HIV self-test, and this was discussed with Kenyan stakeholders who decided HIV self-tests are needed to be used for PrEP initiation, as pharmacies and pharmacy providers are not permitted at the moment to deliver rapid diagnostic tests, or RDTs. We will discuss two of our pilot studies today. One is our model of pharmacy PrEP refills pilot, and this is where clients initiate PrEP at public health facilities and are given the option to refill at pharmacies or stay at the clinic. And our second is our standalone pharmacy PrEP initiation pilot. This is where clients both initiate and refill PrEP at pharmacies. So starting with our pharmacy refill pilot, this was in Thika, Kenya, where clients would initiate at one of two public health clinics and were given the option to either refill at the same public clinic or at one of two nearby pharmacies. We had requirements for our pharmacies, which included being licensed, trained on PrEP delivery, and including a private room for counseling. Eligible clients were adults greater than 18 years at HIV risk and met all eligibility on our prescribing checklist. The cost was 300 Kenyan shillings, about $3 USD per visit at the pharmacy, and it was free at clinics. And you can see on our model below that they would return at 1 month, 4 month, and 7 months for refills with referral to a PrEP clinic afterwards. For our pharmacies, there was also a remote clinician available for any questions during the refill process. Over our pilot duration, we screened 125 clients and ended up enrolling 106. A great majority of them, 41, decided to continue PrEP at the clinic. And it's interesting that about 41% of our participants overall were men, and 88% of those men were older men greater than 25 years old. For PrEP continuation, it showed a high number of participants who chose to continue at the clinic, as featured in blue here. A majority of participants who refilled at pharmacies were men in orange, and we can tell this by the distribution between women and men here. Although a majority of the pharmacy refill clients were male, it was amongst a smaller participant pool. So this suggests there is a potential that men might have a greater acceptability of pharmacy PrEP refills from clinic initiation settings, which we will discuss later on. And I will hand it off to Dr. Victor Amolo to continue with our second pilot study here. And I also would like to mention, apologies, we did do qualitative interviews with participants here to understand why did they prefer refilling at the clinic setting. And it was largely in two parts. One was due to higher acceptability and familiarity with clinic services, also being offered couple counseling in the clinic setting, unlike in our pharmacy setting, as well as other healthcare services. And a second part was some concerns with profit-driven private pharmacies and concerns over privacy within smaller communities among smaller pharmacy settings. But we hope to continue analyzing our qualitative findings in future work. So off to Dr. Victor Amolo.
Thank you so much, Alex, for the presentation. So good evening and good morning, everyone. I'm going to take us through the standalone pharmacy PrEP initiation and refill pilot study in Kenya. This study was conducted in 2 places in Kenya. The first place was in Kisumu County, and the second place was in Thika County. The pharmacies that we selected had to be licensed, had to have a certified pharmacy provider who could assist with doing HIV testing, and had to have a private room where counseling and HIV testing could take place. Eligibility for the clients was that they had to be more than 18 years at risk of getting HIV and meet all eligibility on our prescribing checklist that Alex just talked about. We recruited participants using posters that were put at the pharmacies, and the pharmacy providers also talked one-on-one with the clients that were coming to their pharmacies. Then we had this word of mouth where clients that were enrolled would go and talk to their friends and then encourage them to come to the pharmacies. Clients were charged Kenyan shillings 300 for each service that they received at the pharmacy. The care pathway that we were testing was is shown here. And in this care pathway, it's such that when a client comes to the pharmacy, so the pharmacy provider identifies a client who is purchasing items that may indicate a risk for HIV. For example, emergency contraception, pregnancy test kits, or sex-enhancing drugs. Once they identify them, the pharmacy provider starts the prescribing checklist, which takes the provider through the steps that they're supposed to take when delivering PrEP. And the first section of the checklist was to assess the risk behavior of the participants and also do risk behavior counseling. Once the participants are past that, the pharmacy providers will do medical safety assessment to assess and be sure that the client met the medical, did not have medical conditions that were contraindicated for PrEP. When they got these ones, we advised them to refer these clients to health facilities. When clients passed this, the pharmacy providers assisted them in conducting an HIV self-testing, and if the HIV test was negative, they went ahead and dispensed PrEP to them. Across all these sections of the checklist, when the pharmacy provider was in doubt, we had a remote clinician who could be consulted via phone by the pharmacy provider and could give direction on what the pharmacy provider was supposed to do. So the results that we got, we screened 575 participants. Out of these, we had 476 who were eligible for PrEP, and 287 initiated PrEP at the pharmacies. Of note is that 57% of these were men, and 63% were men above 25 years. On the behaviors that the pharmacy clients had, we found that a majority of them showed risky behaviors for HIV acquisition. For example, they had 84% of them had partners of unknown HIV status, were using condoms inconsistently, and also had multiple sexual partners. Again, of note is that when we stratified this by gender and by age, by gender, we can see that for men below 25 years, we can see 50-50% between men and women, but still we had men who showed high-risk behaviors for HIV, similar presentation to men who are above 25 years, who again were majority of our enrollment. We defined our PrEP initiation. We had on-time continuation and stopping and restarting PrEP. For on-time continuation, we defined this one as a refilling PrEP no more than 15 days after a scheduled visit. And then for stopping and restarting, we defined this as a refilling PrEP more than 15 days after a scheduled visit. So in terms of initiation and continuation, in the pilot, we saw initiation and continuation, which is similar to what we are seeing in the healthcare facilities, which is the standard of care. And you can see that 43% of individuals enrolled came back for PrEP refills at month 1, with that figure going down as we went to month 4 and month 7. When stratified again by gender, we can see that men who are above 25 years had a better continuation rate compared to the other population, with 57% of men who had initiated PrEP coming back for refill at month 1. And that figure also was better for month 4 and also month 7 when we were concluding our study. In terms of acceptability of pharmacy-based PrEP delivery, for both men and women, we found that most of them liked pharmacy-based PrEP delivery. They found it to be easy and not complicated, and also would recommend pharmacy PrEP delivery to their friends or their peers. Amongst men, we saw that they actually had a better acceptability, with a majority of them again liking pharmacy-based PrEP delivery, finding it very easy, and having a higher likelihood of continuing to refill PrEP within the pharmacy, and also would to recommend other people to initiate PrEP within the pharmacies. We also looked at the willingness to pay. And in this, we found that 72% of men were willing to pay for a PrEP service within the pharmacy, either for refill and also for initiation. And actually for initiation, it was 96%. In terms of the amount that they were willing to pay, we also found that men were willing to pay higher compared to women, with men for refill willing to pay about 300 Kenyan shillings. And for initiation, again, the same amount, willing to pay about 300 Kenyan shillings.
Thank you, Dr. Molo. Yeah, thank you, Dr. Molo, for wrapping up our second pilot there. We have a few summary points here that we'll move through. So clients that initiate PrEP at clinics might have already overcome barriers to PrEP access there and prefer continuing there based off of our qualitative findings, thus stressing the need for standalone models of pharmacy-delivered PrEP services to reach new populations. And this standalone model, results from this model suggested we reach men who could benefit from PrEP services as indicated by high prevalence of recent risk behaviors of HIV-associated risks. So our standalone model resulted in high PrEP continuation amongst older adults, with continuation that often either met or exceeded that of public clinics. Pharmacy PrEP delivered services were acceptable and clients were willing to pay. Barriers to scale up included evidence on effectiveness that's needed, costs associated with delivery, and regulatory barriers associated with HIV self-tests for prescribing. In future work, we are going to start enrollment of our 4-arm randomized controlled trial in May of this year to test different models of cost sharing to support these pharmacy-delivered PrEP services. And happy to answer questions on these, but we will have 4 arms, 1 control arm, which will mimic standard of care referral to clinics for PrEP. 1 will include paying a fee at the pharmacy for each visit. 1 will include a free arm, no fee per each visit. And 1 will include us placing a HTS counselor to help with PrEP delivery at the pharmacies with no dispensing fee. Thank you for this opportunity and thanks to the team. We'll welcome any questions.
Thanks, thanks, Alex and Victor for that presentation. We'll allow people to use the chat function so that we can move quickly because of time. Next presenter is James, who's going to present the SAGE study insights on PrEP/PEP in rural East Africa, with an emphasis on men, or the main aspect of that study. So over to you, James. And for any questions for Victor and Alex, feel free to use the chat function to ask questions and they'll be there to respond to them. Over to you, James. Thank you.
Yes, thank you for the invitation. I'm honored to make this presentation on behalf of the SAGE collaboration. I'm James Ayeko from the Kenya Medical Research Institute, and I'm also honored to acknowledge Dr. Kate Koss of UCSF, who is also in the audience today. So SAGE stands for Sustainable East African Research in Community Health. It's a multidisciplinary international research collaboration examining population-level approaches to reduce HIV incidence and improve community health. By way of setting context to our presentation today, I'd just like to start by saying that we design and evaluate multi-disease interventions for persons of all ages and genders. And we have observed over time, just as Sheila mentioned, that men's attitudes and perspective on health require communication and implementation that meet their priorities. Secondly, we have used mixed method approaches in our work to understand what is effective, what is not, and why for men. Our prior work in SAGE on men informed our approach for HIV prevention interventions for men. So allow me to briefly describe our first study here referred to as Search 1.0. This was a pair-matched community randomized trial whose hypothesis was that HIV test and treat with universal ART using a multi-disease patient-centered care model would reduce new HIV infections and improve community health compared to a country guideline approach. This was conducted in 32 communities in rural Uganda and Kenya, shown on the map to the right of this slide. We enrolled individuals aged 15 and above. We started the study by conducting baseline enumeration of the population, followed by HIV testing. So testing was aimed at identifying the group for our intervention, and this taught us very early on that men are distinct. Our model of testing comprised of population-level multi-disease testing using health fairs followed by home-based testing for health fair non-attendees. So with low attendance of men at testing events, we delved into identifying barriers faced by men in accessing testing and learned that factors such as labor opportunities often required extended absences from households, such as fishing among fisherfolk who would be away for weeks to months, and men who had to guard farms from monkeys all day long. Secondly, men often tested by proxy, believing their wives' results to be their status. Masculine gender norms, stigma and fears of accessing HIV services also deterred testing. To reach men, community engagement with male-centered mobilization activities, such as Moonlight Beach outreach and health campaigns with HIV testing, and non-health related attractions such as football matches, boat rowing competitions, bands and theater groups, higher value but fewer lottery prizes were effective. Embedding HIV testing within health fairs with services to address men's needs, such as a men's health tent where issues like sexual health and STI were discussed, as well as partner concerns were addressed, and non-communicable disease screening such as diabetes and hypertension. So with this, the Search multi-disease person-centered approach achieved high adult men testing coverage and status awareness. We had 95% of men living with HIV aware of their status in our communities by the trial endpoint. We registered reduction in HIV incidence with the HIV test and treat intervention, but to even make further reduction in incidence, we added on PrEP. And in these rural settings, men viewed PrEP as a vehicle for reducing their risk of HIV while safely pursuing opportunities for sex, as demonstrated in the excerpts on this slide. Half of the people that we enrolled at this phase were actually men. So despite the effectiveness and advantages of PrEP, it did not fit everyone, with some stopping after initiation. So we must be cognizant that we need prevention options for individuals with unanticipated, periodic, high-risk sexual exposures. So we therefore conducted a small PEP pilot whose results are displayed on this slide. In this pilot, 124 people sought PEP. A third of these were male, a quarter were less than 25 years, 41% were fisherfolk. In terms of exposures reported, 20% reported exposure to a serodifferent partner, 72% with a new and existing relationship, and 7% from transactional sex. 35% of participants reported at least having one out-of-facility or off-site visit. As you see on the left, on the graph on the left, we had high retention, adherence, and testing through this pilot. 88% of our participants completed the 4-week course of PEP, and there were no seroconversions. So what reflection do we carry from this? One is that to reach men, understand their context and adapt your intervention to navigate barriers. Status neutral testing as entry point can be enhanced with multi-disease approach and being responsive to clients' changing needs. Men are interested in health just as everyone else, and there's high interest in PrEP in rural settings among men. Finally, PEP has an important role in HIV prevention among men. With lessons learned from our Search 1.0, we designed Search 2.0, dynamic choice prevention randomized studies, whose hypothesis was that dynamic choice HIV prevention intervention comprising flexibility to switch between prevention options and responsiveness to the needs of both men and women would increase HIV biomedical prevention coverage among persons at risk in rural Kenya and Uganda. So these were randomized trials conducted at 3 distinct settings. One was a community where we screened and enrolled individuals at their households. Second was outpatient department. And thirdly, the antenatal care clinic. We used the PRECEDE framework to develop the dynamic choice prevention model, including PrEP and PEP for both men and women. This model presented product choice of PrEP and PEP and ability to switch between the options. Service location and HIV testing choice, including rapid and self-test, were presented as options. All these were offered within a patient-centered framework as displayed in the blue box. So this slide shows the overall results of the 3 trials as presented at CROI earlier this year. There was an increase of prevention coverage by 40% in the antenatal clinics, 29% in the outpatient department, and 27.5% in the community. I just want to mention at this point that I will present data for men only, so we will focus on results from the outpatient department and community trials only, and only data for men. So let's look at the characteristics of men who participated in these 2 studies. 40% were aged 15 to 24 years, 61% were married or cohabiting, and 77% had a HIV positive partner or a partner of unknown status. So what choices did men make? This graph shows the choices made by men varied with time and setting. In the outpatient department, 87% chose PrEP and 12% chose PEP at least once over the 48 weeks of follow-up. In the community trial shown on the right, 56% chose PrEP and 67% chose PEP at least once over the follow-up period of the study. This next slide shows the choices also varied with regards to testing options, as well as visit location. The upper panel shows choices for participants in the outpatient department trial, and the lower panel shows choices for men in the community trial. Choice of self-testing increased from 34 to 58% in the OPD, and offsite out-of-clinic visits increased from 8% to 50%. For the community trial, self-testing was preferred to rapid testing throughout the study period, and nearly all men chose offsite location for their visits. So you'd argue that choice increased coverage and uptake of these options, or male engagements in these interventions. So what biomedical prevention interventions did men actually use in the SEARCH study? This heat map shows the biomedical prevention coverage among men enrolled in the OPD trial. Let me take a moment to orient you on the interpretation of this graph. Each column represents 1 month in time, and each row represents a man enrolled in the study. The green shows PrEP use, yellow represents PEP use, and red shows no intervention use. With that, I'd like to turn your attention to the combined proportion of green and yellow, assuming risk in the background. The intervention succeeded to cover a significant proportion of time that would translate to reduced infection in men in the background of risk. So men start PrEP and PEP, and they indeed take it over the course of their risk. So this next heat map shows the biomedical coverage in the community setting. There was lower PrEP use, as you can see when you compare to the previous one. However, I'd like to emphasize the higher use of PEP going by the yellow on this graph. These are periods of risk when men, despite knowing that PrEP availability in the community, that there was PrEP available in the community, they ended up choosing PEP. In the prevention armamentarium, I would argue that PEP needs to be given more emphasis as an effective prevention option for use beyond occupational exposure, because it has its place in prevention. Overall, our dynamic choice intervention increased biomedical coverage on those enrolled in the outpatient department by 31%, as depicted in this graph, during periods of self-reported risk of the intervention, increased coverage by 45.1%, both effects being slightly larger in men than women. In the community, the intervention increased biomedical coverage by 29.4% overall and 37% during periods of risk. So we conducted a survey on barriers and facilitators of PrEP and PEP uptake across studies, and these were the results. They were pretty similar to what Sheila and her team found in South Africa. Pill burden and size, fear of side effects, concerns about being perceived as HIV positive from using antiretrovirals, fear of partner knowing, travel or being at school, and forgetting to take pills were identified as barriers to uptake and use. On the other hand, clinic and peer education, patient-centered non-judgmental care, client choices prioritized and supported by providers, even when there's ongoing risk and provider might think PrEP might be more effective, the option to go on and off PrEP, flexibility in visit location to reduce stigma, and pill in pocket options were viewed as facilitators of uptake and use. So from our dynamic choice HIV prevention intervention, I'd like to highlight that our DCP intervention increased prevention coverage by greater than twofold compared to standard of care among men. Men embraced the opportunity to change strategies over time. Uptake of biomedical prevention differed among men by setting. However, there's still a gap in coverage and there's still need for additional options. To do this, we continue to expand options for prevention to push the prevention coverage even higher within the study. And so we therefore added long-acting cabotegravir injection, which we hope will overcome some of the barriers to oral PrEP uptake and use. For this, we have a 48-week extension, and that allows us to make a number of comparisons, including within and between arms. And men have enrolled and taken the injection in these rural settings, and the study is ongoing. So in summary, men with risk factors can and should be reached for prevention services in sub-Saharan Africa, and such dynamic choice prevention model with patient-centered delivery model offered higher prevention coverage than standard of care for men, and men are interested in long-acting Kabele and are initiating on it. Finally, our gratitude to participants, communities, funders, ministries of health, and collaborating institutions, and thank you for your attention.
Thank you so much, James, for such an excellent presentation, showing insights from the SAGE study on PrEP/PEP among men. Are there any questions? I know the chat box has been very active, and I've been seeing panelists have been responding to questions in the chat box. anyone who would like to say something to ask through your mics, please raise your hand. We can allow your mic to be unmuted, and then you can ask questions to James. And also for the other presentations as well, if you felt you needed to comment via the mic and not only through the chat box, feel free to indicate by your hand, and then we can allow you to speak. Any questions for James? I see a hand. Let's see. Nicholas, can you check, because I can't see from my side who is raising hand, if you can allow the person to unmute. Yeah, it's beloved Manasidze. Can you unmute? Hi, Nicholas.
Yes, sorry, Lysias.
Would you allow beloved to unmute so that you can ask questions to the presenters?
Sorry, who?
Beloved, the one with the hand raised.
I don't see them anymore, actually.
Do you still want to ask, beloved? I see your hand is down now. Do you want to speak, or? Yes, the hand is up. If you can allow you to unmute.
Okay.
Beloved.
Yes.
Manasidze, beloved Manasidze.
Ah, yes, I can see. Let's talk. Waiting for, yeah.
You can speak, beloved. You should be able to speak.
Yeah, thank you very much. It's beloved from ANOVA Health Institute, South Africa, Men's Health Services. I just want to find out, because I saw from the last presenter, there seemed to be more interest to take PEP as opposed to PrEP. I just want to find out during their studies if they had a chance to engage men or to investigate what the reasons were in terms of sexual risk behavior. Because I would want to believe that logic would say someone needs to be more precautious and prevent as opposed to go for post-exposure prophylaxis. What were the findings, if any, along that? And then the second one, I also saw that there is a high uptake of HIV/SS. In terms of case finding, what do you have any insights in terms of yield as a modality? Is it giving good results? Thank you.
Yeah, thanks, beloved. And kindly, I wouldn't want to take Alex and Victor's time as well as Sheila. Feel free to ask any of us questions. Beloved, on your question of interest, I would say that, of course, PrEP uptake was still higher than PEP, but the pilot really showed us that there's a space and an opportunity for PEP, and that should be seized. One of the challenges with oral PrEP was, just the fatigue that sets in with an oral daily pill. And somewhat PEP, on the other hand, when you see the end in sight, adherence is pretty good even after an exposure. And so we're saying that sometimes you'll come across people who have periodic risks, and sometimes there are even cases that as a clinician you may feel PrEP might be more appropriate. But indeed, if PEP is what is going to work for that patient or client, then we should give that allowance to ensure that we avert infections. But overall, PrEP was high, uptake was higher or in terms of PrEP, but we included the option of PEP pill in pocket. So someone would have PEP with them and start it after a high risk exposure. And that also had its pace. I hope that answers your question, beloved. So your second question was on case finding. I didn't fully understand it. Did what approach improve case finding?
Yes, beloved, would you like to clarify on that question on case finding? You should be able to unmute.
Oh yeah, no, I just wanted to find out if it's in terms of yield, right? As a modality, whether it's really giving helping identifying cases. And also maybe I'm getting too far whether the HIV/AIDS was it primary or secondary, and what the findings were in that regard.
Yes, Zembe, and I hope I've understood the question. In terms of follow-up testing for the cohort, indeed there were a negligible number of seroconversions. I don't know if that is a question, whether we end up identifying people at high risk who seroconvert. But the ones that we've had in our large cohort have been very few. And in terms of evaluating their exposure, or rather their history of taking PEP or PrEP prior to their seroconversion, it has almost invariably been that those participants had been off biomedical intervention.
Thank you, James, and thanks for those follow-up questions, beloved. Anyone with any comment, question? I see the chat box has been very active, and panelists have been responding to questions. Anyone who feels they've posted questions but they've not been responded to?
So Zembe, if you allow, I think one of the participants had asked about how we fostered continuation. One is that we offered a client-centered approach that was able to listen to barriers and adjust to address whatever barriers that there might be. If home is not a good place to visit, then we would offer options of where can we see you, and so on and so forth. And then we also offered choice. So you can switch from one modality to another and see if that works best for you, based on your lifestyle or where you are at in life. And then we also accounted for, changing exposure and circumstances over time to ensure that we have a plan to restart whenever you want to start PrEP, or if you want to go on PEP, you'd always have a pill in pocket if you had chosen that. So I hope that helps. Thank you.
Thanks, James. And I see Sheila. Sheila's hand is up. Over to you, Sheila.
Thank you. Just wanted to follow up on that, James. Thank you so much for a wonderful presentation. Very exciting, and certainly in line with our experience in South Africa. A lot of the similar findings. I'm wondering about your comment about being able to facilitate access regardless of where patients are, and continuing and transferring different modalities and such. I think we've had a lot of challenges with the rigidity of the public sector system, and I'm wondering how you've navigated that in terms of trying to make things, trying to facilitate care for your clients.
Yeah, so like in the community, we've used already existing structures. Like in rural Kenya, I believe in many of these settings might have a similar structures where we have community health volunteers who are able to reach participants for other issues of health, antenatal care attendance, children vaccination, and so on. And so we ride on that system to see if someone needs a refill of PrEP, where would they want to get it? And it's just getting the drugs from the clinic, and while they're doing the other activities, they should be able to deliver it. If they want to meet at the nearby center, that also work. But flexibility in terms of appointments at the clinic has been very deliberate in terms of trying to ensure that providers can set appointments with the clinics, with the participants on whether they want to come in early or in the late hours of the evening before they retire or they go for fishing. So that kind of flexibility, there probably are systems that exist that present opportunity to ride on, and of course with our encouraging flexibility on the provider side to cater for participants whose schedule might not fit in the traditional health center schedule.
Thank you. That's wonderful.
And while you're still there, James, I see a question from Wile saying, what is the treatment/dose completion rate for PEP if pill burden is part of the noted challenges? Do you have any response to that question?
Completion rate of PEP?
Yes. The treatment dose completion rate for PEP if pill burden is part of the noted challenges.
Oh, yes. So the pill burden issue is, the survey was assessing both PrEP and PEP. But in the pilot, as I indicated, we had 88% completion rate. Not everyone completed, but I think 88% is a pretty decent completion rate. Taking in mind that no one knows for sure how long, we are able to say this duration is the most effective. However, I think for the pilots that we have, 88% was the completion rate.
Thanks, James. And the last comment I'm seeing under the Q&A is the comment from Mona, just highlighting that she's glad to hear this comprehensive approach, and that MENA is interested in their own health as anyone else, which is what we'd like to see. Yeah, thanks for that comment there, Mona. So that's all I can see. I'm not sure if I missed any question in the chat box or in the Q&A session. Otherwise, I'll hand over to my friend and colleague Wale from WHO to give us closing remarks. Yeah, thanks to you all for being an engaging audience, and thanks to all our presenters. Over to you, Wale.
Thanks, Lysias. I'll just echo what you've just said. I think it's been a very lively session. I think for the quality of what I've just seen, from the presentations, but also from people in the chat box, I always wish we could drive even more participation. So it's a call to everyone who's responding in the Q&A in the chat box, to let's make these sessions even more global. They're supposed to be global webinars, so let's share the links and let's drive as much participation in these webinars as much as possible. Just a few reflections before I close. I saw Julie's post in the chat box, which asked the question. I felt it was more it was rhetorical, but it's also a very cogent question. Are we sufficiently addressing barriers related to gender dynamics and stigma, et cetera, et cetera? And that sort of tells you one thing. It is less about what models we have, but more about making sure that those models are differentiated and that they provide the services that men need. And I think this reflects as well what Mona and others said in the chat box, that really men would come to services, whether facility or community or other based models, as long as we get those things right, the options, the design, the convenience, as well as the benefits that accrue to men when they visit these services. In the first part of the webinar series, on men and PrEP, there was what I thought was a very fantastic quote from Danvik, who said, there is more to demand generation. Demand generation goes way beyond just creating demand. It's about, as well making sure that when we then get those demands, we sort of make them holistic. We provide quality and comprehensive services. Secondly, I would just like to say, something similar about avoiding the usual traps. We need to make sure that, the fantastic models that have been presented here from colleagues inspire new ways of doing things. There's no point, moving into new models when we still do the same things over and over again. So the more things change, the more they should not remain the same. We have to shed the toga and the skins of those things that Sheila mentioned and James and Alex as well, on stigma that has been seen, but also shedding that toga of vertical programs. It's not just about PrEP, it's about PrEP and integrated prevention as well, and changing the different narratives, the assumptions that we have of men. And then finally, all of the things that you've presented so well are, the different dots. But like we know, we have to make sure that we sort of connect the dots. How do we come together to make sure that, the destination that we have in providing services to men and making sure that men are at the right side of history and ending AIDS, how do we make sure that those dots are connected? And it's about the science. We have to make sure that we follow the science, the evidence. I think Robin's presentation on clarifying the guidelines, really, really helped. But of course, we got that clear message on trying to simplify our communication and making sure that the messages that we push out are as clear as possible. Of course, we have the MENT platform to help us to connect those dots. We want to continue to bring out those best practices, promote uptake, and build bridges, of course, from north to south. We have the other webinars that are coming up. So on April the 13th, that's today, we've done Men and PrEP, the second part. The idea is to have another one in June and another in September and November. I put this as tentative dates because we want to make sure that we get it right, get the quality right, drive the attendance as well. But these are the sorts of tentative dates that we have for the moment. So it's just to thank all of you. I thought it's been a very fantastic show. I'm going to, just say huge thanks, of course, to Robin, to Sheila, Alexandra, and Victor. My very good friend James as well gave a really great presentation. So thanks so much to all of you. Not forgetting the, the interpreters and the technicians who have made sure, who have tried as much as possible to make sure that we have as hitch-free a session as possible. We continue, to build bridges. We continue to, to seek these practices. But I think we just have to make sure that, we take that further step. It's about what next, what happens, and so what? How can we make sure that these best practices, get into programs towards improving uptake and outcomes for men in all their diversity. On that note, I'm going to say thank you so much, and we'll see again. Let's spread the message, and we'll come back again for the next MENT webinar series. Thank you so much, and bye-bye. Take care.